Hello everyone, welcome back to Biomed Prep, the channel dedicated to helping you pass your medical board exams and become a confident, clinically sharp doctor. If you are preparing for the OSCEs, this is a video you absolutely cannot afford to skip. Today we're going through 10 high-yield surgical stations that test not only your knowledge, but more importantly your clinical reasoning and structured approach to patient care. The exact wording of questions may vary, but the goal here is not memorization. It is understanding the clinical approach so that no matter how the question is framed, you will know exactly what to do. All right, let's dive straight in. We begin with a classic trauma emergency, flail chest. Flail chest occurs when two or more consecutive ribs are fractured in at least two places, creating a free-floating segment of the chest wall. What makes this condition so dangerous is something called paradoxical breathing. Normally, during inspiration, the chest expands outward as negative pressure draws air into the lungs. But with flail chest, the unstable segment moves inward during inspiration and bulges outward during expiration. This severely compromises ventilation and can rapidly lead to respiratory failure if not managed promptly. On examination, inspection is your best friend. Look carefully for paradoxical chest movement. It is often the clue that earns you top marks. When you palpate the chest, the patient will typically experience significant pain over the fractured ribs, and you may even feel crepitus if the fractures are severe. Percussion may reveal a hyperresonant note if a pneumothorax is present, while auscultation often demonstrates reduced air entry on the affected side. Management should immediately trigger an ABC mindset: airway, breathing, circulation. First, secure the airway. Many of these patients require intubation with positive pressure ventilation to stabilize the chest wall and improve oxygenation. Administer high-flow oxygen and position the patient upright or on the affected side to optimize ventilation perfusion matching. Next, establish IV access. Send blood for a full blood count and begin fluids if indicated. Never underestimate pain control. Adequate analgesia allows the patient to breathe more effectively and prevents further complications. If complications such as pneumothorax or hemothorax arise, insert an intercostal drain promptly. Broad-spectrum antibiotics and tetanus prophylaxis should also be considered in trauma settings. In OSCEs, always prioritize life-threatening conditions first. Examiners reward safe doctors. Let's move on to Station 2. Imagine a 40-year-old man presenting with epigastric pain, dyspepsia, and now generalized abdominal tenderness. He shows you an image from an investigation. The investigation performed here is a gastroscopy, and the pathology is most consistent with a peptic ulcer. When discussing risk factors, you should confidently mention smoking, infection with Helicobacter pylori, and excessive alcohol intake. These factors disrupt the protective mechanisms of the gastric mucosa, making it vulnerable to acid injury. Now comes the dangerous complication, gastric perforation. When an ulcer erodes completely through the stomach wall, gastric contents spill into the peritoneal cavity, leading to chemical peritonitis. This is a surgical emergency. To support your suspicion, a full blood count may reveal reduced hemoglobin if bleeding has occurred, while a urea breath test can confirm the presence of H. pylori. Always remember additional complications, such as hemorrhage and malignant transformation. OSCE examiners love asking for 2 other complications, so never stop at just one. Next, we have a 40-year-old chronic smoker presenting with darkened toes. Your diagnosis here should immediately be peripheral vascular disease, leading to dry gangrene tissue death caused by prolonged ischemia. History taking is critical. Ask about diabetes, family history of vascular disease, intermittent claudication, prior trauma, and any abnormal sensations like tingling or numbness. Investigations should focus on assessing blood flow. Angiography provides detailed vascular imaging, Doppler ultrasound evaluates circulation, and blood tests such as HbA1c and lipid profiles help identify underlying metabolic contributors. Treatment begins with the most powerful intervention of all, smoking cessation. Without eliminating the primary cause, other treatments lose effectiveness. Medical therapy may include broad-spectrum antibiotics if infection is suspected, while surgical options such as transluminal angioplasty can restore perfusion. Always address modifiable risk factors. It signals maturity in clinical thinking. Now consider a 45-year-old patient with right upper abdominal pain and visible scleral changes suggestive of jaundice. Your history should target features of cholestasis. Ask about itchy skin, pale stools, dark urine, pain after fatty meals, and fever. Investigations should include serum bilirubin, particularly conjugated bilirubin, liver function tests focusing on alkaline phosphatase, abdominal ultrasound, and possibly ERCP to visualize the biliary tree. If the patient mentions difficulty seeing at night, think fat-soluble vitamin deficiency. When bile flow is obstructed, absorption of vitamins A, D, E, and K is impaired. Vitamin A deficiency specifically explains poor night vision. Link symptoms back to physiology, That is how distinctions are earned in OSCEs. Next station. A patient presents with anterior neck swelling but normal thyroid function tests. This suggests a euthyroid goiter. You should be comfortable describing thyroid hormone synthesis. First, follicular cells actively uptake iodide from the bloodstream. Next, the thyroid produces thyroglobulin. The enzyme thyroid peroxidase then oxidizes iodide, allowing iodinated tyrosines to couple and form the hormones T3 and T4. Investigations include thyroid function tests, antibody testing for autoimmune disease, and radioactive iodine uptake scans. Now here's the twist. After surgery, the patient cannot sing high-pitched notes. This should immediately make you think of recurrent laryngeal nerve damage, which affects vocal cord movement. Always mention nerve injury when discussing thyroid surgery complications. In the next station, an intraoperative image reveals a stoma, specifically, a double-barrel colostomy. A stoma is a surgically created opening that brings part of the bowel to the skin surface, allowing fecal diversion. Indications may be congenital, such as megacolon or anal atresia, or acquired, including ischemic bowel disease, trauma, tumors, and volvulus. Complications can be divided into general and specific categories. General complications include fluid and electrolyte imbalances, nutritional deficiencies, stone formation, and psychosocial distress. Specific complications involve ischemia of the stoma, stenosis, prolapse, and skin irritation. Separating complications this way demonstrates organized thinking, something examiners notice immediately. Now let's talk about acute appendicitis and the famous Alvarado score. Use the mnemonic MANTRELS to remember the parameters: migratory pain, anorexia, nausea and vomiting, tenderness in the right iliac fossa, rebound tenderness, elevated temperature, leukocytosis, and a left shift of neutrophils. The higher the score, the greater the probability of appendicitis. Complications you should mention include perforation, peritonitis, appendicular abscess, and appendicular mass. Always provide at least 2, never leave easy marks behind. Next is a patient with dysphagia to liquids who undergoes a barium swallow, showing the classic rat tail sign. This points toward achalasia cardia, a condition in which the lower esophageal sphincter fails to relax. Ask about aspiration pneumonia, retrosternal discomfort, painful swallowing, and weight loss. Further investigations include esophageal manometry, the gold standard, along with endoscopy and chest imaging. Whenever possible, mention the gold standard test. It signals deeper understanding. Now imagine a patient arriving in the emergency department with upper airway obstruction who undergoes a tracheostomy. This procedure creates a direct airway through the neck and is indicated in situations such as laryngeal abnormalities, inhalation burns, severe infections, and laryngeal cancer. If the tube becomes blocked and oxygen saturation drops to 80%, the resulting condition is hypoxemic hypoxia. Other forms you should know include ischemic hypoxia, anemic hypoxia, and histotoxic hypoxia. Classification questions are often easy scoring opportunities. Don't miss them. Finally, we have the Burgess technique of below knee amputation. The tibia is typically cut about 12.5 centimeters below the knee joint, with the fibula slightly shorter. A long posterior flap is created to provide cushioning for weight bearing. Indications can be remembered using the 3 Ds. A dead limb, such as one affected by gangrene or embolism. A dangerous limb, as seen in crush injuries or aggressive tumors like osteosarcoma. And a damn nuisance, severe deformities, paralysis, or contractures that drastically reduce quality of life. Examiners love memorable frameworks like this, and that brings us to the end of today's high-yield surgical OSCE review. If this video helped clarify these critical stations for you, make sure you like the video, subscribe to Biomed Prep, and share it with your study partners, because medicine is tough, but it's a little easier when we learn together. Remember, OSCE success is not about cramming the night before. It's about developing a calm, structured clinical approach that you can rely on under pressure. Keep studying smart, stay consistent, and I'll see you in the next video.